When you think of the first thing that comes to mind when you hear the words blood loss or hemorrhagic shock, you might think of bags of IV saline hanging over the victim. Seemingly unassuming, yet simultaneously ubiquitous, these bags of clear fluid have been standard of care for many years when treating victims of hypovolemia due to hemorrhage from trauma. The rationale is simple, after all. The patient's brain and other vital organs are not being adequately supplied with oxygen due to insufficient volume, which saline aims to correct by simply raising that volume to correct for the imbalance. Yet, in the modern trauma center, you'll almost never see them around today's trauma patient. Why might that be? In this video, we'll be taking a look at the rise and fall of this outdated medical practice. The circumstances of normal saline's invention actually had nothing to do with trauma. In 1831, a pandemic of cholera swept through Europe, which prompted medical practitioners to seek effective treatments for this disease that most often killed through dehydration. In fact, the first rudimentary IV fluid therapy was first practiced on such a cholera patient, with a chemist injecting water directly into their body. This was problematic as, well, blood isn't water. Putting aside the vast array of different cells and proteins seen within the blood has a very specific concentrations of ions that maintain a careful osmotic balance in the body. If the ion concentration within the blood was to fall, then due to osmosis, water would rush into cells, bursting them open and killing them. This problem was recognized, and thus began an effort to not only identify the ions found in blood, but also create a synthetic solution that mimics those concentrations. These efforts resulted in the normal saline that we know today, which is really just a solution of 0.9% sodium chloride dissolved in water. It was deemed acceptable and has been used widely to replace lost fluids ever since. In its original role, saline works wonders to treat dehydration and restore electrolytes. However, its use in trauma is cited as the triumph of hope and wishful thinking over physiology and experience. Let's consider what trauma and the subsequent hypovolemia and hemorrhagic shock actually entails. In the most literal sense, it can be considered as a failure of the circulatory system that serves to transport oxygen from the lungs to the body's tissues due to a lack of blood. This oxygen insufficiency then causes the body to switch over from aerobic to anaerobic respiration, or the breakdown of glucose to produce 2-ATP and lactic acid. This lactic acid thus causes the reduction of blood pH or acidosis within trauma patients. Additionally, as the body struggles to produce ATP, it also suffers from hypothermia, since aerobic respiration is what generates heat in the first place. One of the ways that the body defends against these problems is by forming clots to stop blood loss, but as blood volume drops, so does clotting ability, leading to coagulopathy, or the inability to form normal clots. These three factors is what's called the lethal triad of trauma, with metabolic acidosis, coagulopathy, and hypothermia being the key players in a positive feedback loop that eventually causes death. Treatments, therefore, should serve to break this cycle while also reversing some of these effects, with the end goals of trauma resuscitation being broadly the restoration of circulating volume, oxygen delivery, normal body pH, as well as hemostatic or clotting ability. The first point, circulating volume, is often cited as the justification for use of normal saline, with the extra volume pushing around available red blood cells and thus improving volume and oxygen delivery. However, normal saline administration often worsens both metabolic acidosis and clotting ability. Speaking to the former, remember those ions that we discussed earlier? Well, normal saline actually has an excess of chlorine ions in comparison to blood. This is not a problem in most cases, but transfusing these excess ions into a body that is already suffering from acidosis only worsens the problem. The excess chloride causes basic bicarbonates to leave the blood and thus lowers blood pH. This was demonstrated in animal models, with the administration of normal saline directly causing hyperchloremic acidosis. In terms of the second point regarding hemostatic ability, normal saline obviously contains no clotting factors and actually serves to dilute the clotting factors that are already present. Given that factors need to find each other in order to take their place in the coagulation cascade, the increase of what is effectively empty space between them often makes it even harder to do so, worsening another aspect of the lethal triad. Additionally, the sudden spike in blood pressure from large amounts of normal saline administration can often disturb blood vessels and sometimes even destroy clots that have already formed, further complicating the situation. So, there's the physiology. But what about the evidence? Saline's harms were noted upon as far back as the First World War, with Canadian surgeon Dr. Robertson advocating for blood transfusion over saline, as the effects of a saline transfusion are transitory, a flash in the pan, followed by greater collapse than before. However, he was criticized by the surgical community at large, who championed saline as a safe and simple method of fighting hypovolemia. More recently, the US Army conducted a study that involved analyzing their records treating the wounded in Iraq and Afghanistan, with the results pointing to the fact that saline administration often increased mortality. As a result, saline use was discontinued in favor of whole blood or plasma transfusions. In all, the past use of saline represents a dangerous misunderstanding of the nature of trauma and the ways in which it causes death, with its abandonment in modern medical practice a major success brought on by evidence-based medicine. Blood is the only substitute for blood, and its use in both hospitals and now even the pre-hospital environment will surely save far more trauma patients than saline has ever harmed.